Hi, I'm Dr. Harmony Reynolds from the NYU Grossman School of Medicine, and I'm here with Dr. Eileen Handberg of the University of Florida. She is the lead investigator of the Warrior trial who presented this morning. It was really a great buzz in the room, Dr. Handberg. It was so exciting to hear your presentation, and I know that I and my patients have been waiting for this one for a long time. Congratulations.
Thank you.
This was very well received, and it's a study that was critically needed. I wonder if you could walk us through the top line results.
Warrior was the effort of a long history of looking at women with INOCA, which is angina or ischemia without obstructive coronary disease. We had some data from early trials showing some potential therapeutic opportunities to improve symptoms and outcomes. And so we designed a trial to examine the use of intensive medical therapy versus usual care in these women with INOCA. And so the trial was designed to determine if the intensive medical therapy, which consisted of a high-intensity statin, moderate dose of ACE or ARB, and a baby aspirin, compared to usual care, could reduce the occurrence of MACE events, all-cause death, non-fatal MI, stroke, hospitalization for heart failure or angina over the duration of follow-up. So we randomized these women who had signs and symptoms of ischemia sufficient to either have coronary angiography or coronary CTA to define their anatomy and had non-obstructive disease. They were randomized to either arm and then followed basically for 3 to 6 months and then every 6 months for the duration of the trial. We were able to enroll 2,476 women. Unfortunately, the pandemic occurred in the middle of the trial, which resulted in our inability to meet our recruitment goal of 4,422 patients. So we ended up enrolling a population of women who were predominantly white, overweight, mean age of about 62, who had comorbidities of hypertension, current or past smokers, diabetes, and who were relatively well controlled in terms of their blood pressure. Their mean blood pressure was 120, 125 at study entry, and who had lipid levels around 93 to 96 LDLs. And so a lot of these women, because of their comorbidities, were on a background therapy of statin and ACE or ARB at entry into the study. We were able to demonstrate follow-up over the extended conduct of the trial, but we were unable to confirm the primary hypothesis. So there was no difference in the MACE outcomes over the course of the trial between the two groups.
And do you see this as a negative trial?
I don't. This is a neutral trial, and I think that's extremely important. It's the largest INOCA trial, randomized trial that to date. So the information is extremely important. We were not able to answer the question because we didn't have good enough adherence to the intervention, and we had inadequate sample enrolled to be able to have adequate power.
It's important that I think that Warrior was a pragmatic trial, and it had to be. You know, it's done very well, but you put a lot of measures in place to make sure that patients had access to their medications and to make it easy for people to participate that I think will be important features of future clinical trials. And I wonder if you could speak to those.
Sure. I think with the expense that you see with large-scale clinical trials, especially pragmatic trials, you have to put in the things in place that will make it easy for sites and for participants. So we had, as many trials do today, an electronic data capture system that randomized patients, developed the prescription that the provider needed to look at, which then distributed directly the prescription to the pharmacy, either a central pharmacy or a local pharmacy. The meds were delivered directly to the patients, helping to improve compliance and starting of that therapy. So that's extremely important. We had a central IRB. Obviously, that's kind of mandated these days. E-consents. So the process was as smooth as we could make it for the patients and the site.
That's very important. What do you think about the risk level of the patients who were identified when you look at the outcomes? Do you feel like you hit the right target?
We did for the women who went for coronary angiography. They had a risk profile that was a little bit higher. We've compared those two populations in a published paper. The risk profile for the coronary CTA group was less. They had less comorbidities, and I think that helped reduce our risk profile. And so I think if we were to develop a new trial, we would probably need to do inclusion criteria that enhanced risk, because we ended up with Seattle angina less than or higher Seattle angina questionnaire values, which indicate less angina. And what we see in clinical centers like yours, like ours, where we take care of this population of women, they have a lot of symptoms, and yet the scores didn't really support that over the whole group that was enrolled. But if you look at the MACE events, the highest MACE event in this trial was recurrent hospitalization for angina, and there were about 300 in each arm. So 1 in 4 of these women were going back to the hospital to be seen for recurrent angina. And that's where we see a lot of burden for both the patients and the healthcare system, and that really impacts quality of life. And so if we can, in the next trial design, enhance the risk, take care of identifying these women, and reduce hospitalization, it would be a home run, right? And so it's a matter of getting that design tweaked so that we can do that.
Absolutely. I certainly see a lot of those cardiovascular hospitalizations in my practice also. So I think that you were getting to the heart of the matter. I know you have some ancillary studies that will report soon, and I know you can't share results with us, but what should we look forward to hearing about?
We have 3 ancillary trials that were funded during the course of the Warrior trial. 2 that look at the women enrolled who had their anatomy defined by coronary CTA. So one trial funded by NHLBI is looking at baseline and 3-year follow-up CTAs using AI-enabled a methodology for quantitating plaque and looking and then correlating that data with quality of life outcomes. The second trial funded by DOD called Quiet Warrior is also looking at that population of women who had CTA and using that same analysis methodology, AI enhanced, and correlating those findings with MACE outcomes. So we think that will help us understand a little bit more perhaps about progression and mechanism of disease. We had a third trial. It's not a trial, but it's a biorepository that was funded from philanthropic support that we have collected samples on this population. So probably the largest biorepository sampling in a very well-defined cohort of non-obstructive women that we will be able to look at biomarkers, look at and try and personalize treatment going forward.
It's going to be really exciting. I mean, it's such a huge data set of carefully monitored patients, almost 2,500 women with INOCA. It's a huge milestone for the field. And I really do want to congratulate you, Dr. Pepin, Dr. Barrymers, and the whole Warrior team on this fantastic effort. Thanks for joining us today.
Thank you so much for having me.